Hello, and welcome to today's talk on epilepsy. Over the next several weeks, through a series of seminars, we will be learning about the definition, classification, clinical features, and treatment of epilepsy. Session 1, Introduction to Epilepsy. Objectives. At the end of the session, you will be able to describe the epidemiology and impact of epilepsy, particularly in low and middle income countries. You will be able to define epilepsy and seizure, as well as understand the difference between the two. You will be able to classify the types of seizures and epilepsy, as well as apply these definitions and classifications to clinical scenarios. Epidemiology of epilepsy. Epilepsy is one of the most common chronic neurological disorders. It affects almost 70 million people worldwide. According to the Global Burden of Disease study published in 2010, epilepsy represents 0.7% of overall GBD measures in disability-adjusted life years. Although a global disease, it is unequal in distribution. Almost 80% of those affected by epilepsy reside in low and middle-income countries. It is considered a treatable condition with high rates of therapeutic response. Over 70% of patients with epilepsy are controlled with anti-epileptic drugs. However, around 73% of patients with active epilepsy in low and middle-income countries, particularly in rural areas, either do not receive appropriate treatment or do not receive treatment at all, thus resulting in what is called the epilepsy treatment gap. What are some of the main causes of the epilepsy treatment gap in low-income populations? The causes, as you can imagine, are multifactorial and can be divided into two categories: healthcare system and patient-related reasons. What are some of the healthcare system-related reasons? Cost of treatment, limited availability of anti-epileptic drugs. As you know, in Rwanda, certain drugs like Keppra are not available at the district hospital and health center levels. There can also be challenges with the supply chain. Inequity in the distribution of economic resources between public and private sectors. Limited number of specialists such as neurologists and epileptologists involved in epilepsy care. As we know, most neurologists in Rwanda are concentrated in the urban areas such as Kigali. Limited opportunities for diagnostic methods. MRIs are not easily available. And for CT scans and EEGs, patients typically need to travel long distances with referrals in order to get them. What are some of the patient, caregiver, and community-related reasons? They may hold certain cultural beliefs that prevent them from seeking care. They may reach out to alternative and traditional treatments first before seeking medical treatment. They may have negative attitudes or fears about biomedical treatment. There can be social stigma surrounding epilepsy, and patients may have to travel long distances to health facilities, especially when they reside in rural areas. What are some of the causes for this treatment gap that you see in your practice in Rwanda? What are some of the cultural beliefs you have heard from your patients? Do you see a lot of stigma with epilepsy in your communities? And why do you think that is? As mental health providers, even though we are not specialists in neurology, we are responsible for caring for a majority of epilepsy patients in Rwanda. We are trained to think about patient management from a biopsychosocial perspective. And just like in mental health patients, thinking about epilepsy treatment from a biopsychosocial perspective can go a long way to understanding some of the reasons behind the epilepsy treatment gap and also in addressing some of these reasons. Definitions. What is the difference between a seizure and epilepsy? A seizure is the symptom or event. Epilepsy is the disease associated with spontaneously recurring seizures. To understand this better, we can broadly compare it to psychosis and schizophrenia. Psychosis is the symptom and schizophrenia is the disease. When a patient has a single episode of psychosis, we do not diagnose them with schizophrenia. When a patient has a psychotic episode due to an underlying medical condition or alcohol use, for example, we do not diagnose them with schizophrenia. We typically wait for the patient to have multiple episodes of psychosis over a period of time in order to make a diagnosis of schizophrenia. Similarly, if a patient has a single seizure, we do not diagnose them with epilepsy. And if the seizure is due to an underlying medical condition, we do not diagnose epilepsy. We wait for the patient to have spontaneous, unprovoked, recurring seizures at least twice in order to make a diagnosis of epilepsy. In Rwanda, we use the word crisis to describe a seizure. This likely comes from the French term for seizure, crise d'épilepsie. However, in medicine, crisis is a very general word. It's used in several medical situations, such as a hypertensive crisis, diabetic crisis, thyroid crisis, to name a few. We even use it in psychiatry to describe a mental health crisis if a patient presents with agitation or suicidality. And for this reason, it would be best to use the word seizure instead of crisis to describe the event with more clarity. So what is a seizure? A seizure occurs when there are excessive nerve cell discharges in the brain. These excessive nerve cell discharges or excitation can occur in a small area of the brain, giving rise to a focal seizure, or they can affect the whole brain, causing a generalized seizure. These abnormal discharges can vary in site, severity, and extent, leading to the wide variety of clinical presentations that we see in epilepsy. We have all heard the words convulsion, fit, attack, and crisis being used, and they all mean the same thing: seizure. What is epilepsy? The word epilepsy comes from the Greek language and it means to be taken, seized, or attacked. Epilepsy is a disorder of the brain characterized by repeated seizures due to a disorder of the brain cells. It typically has a lifelong tendency. For example, if someone has a seizure in childhood, they have a lifelong risk of having another seizure. However, seizures can start at any time during a person's life. As we have seen in our practice, they can occur sporadically, meaning once in several years, or frequently, even several times a day. There are two kinds of seizures, provoked and unprovoked. Provoked seizures occur secondary to a particular identifiable event or medical condition, such as trauma to the brain, an infection or tumor in the brain, electrolyte disturbances in the body, or alcohol and drug withdrawal, etc. In unprovoked seizures, there is no identifiable underlying cause. We have talked about the definitions of epilepsy and seizure. We have also talked about the difference between epilepsy and seizure. We've established that when a patient has a seizure, he or she isn't automatically diagnosed with epilepsy. So when is a person diagnosed with epilepsy? Here we have a practical clinical definition of epilepsy. Epilepsy is a disease of the brain defined by any of the following conditions. At least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure and a probability of further seizures, or a diagnosis of an epilepsy syndrome. Epilepsy is considered to be resolved for individuals who had an age-dependent epilepsy syndrome but are now past the applicable age, or those who have remained seizure-free for the last 10 years with no seizure medications for the last 5 years. There is varying understanding of when epilepsy is resolved and when to stop medications in the literature. We will discuss this in a later session. The most important thing to remember from the slide is that epilepsy is diagnosed when a person has at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure with a probability of further seizures occurring. We will discuss these in the context of clinical scenarios later in this session. Listed below are types of seizures that are not epilepsy but due to an underlying medical condition. In these patients, in the absence of the underlying precipitating factor, the risk of seizure is actually pretty low. For example, febrile seizures in children typically aged 6 months to 6 years. In the absence of high-grade fever, the risk of seizures in these children is low. So the most important thing to do in these children is to bring down the fever and treat the cause of the fever rather than the seizure. Alcohol withdrawal seizures. In these patients, it's more important to treat the withdrawal with a benzodiazepine such as diazepam rather than treat the seizure with an antiepileptic medication. Metabolic seizures, which can occur due to varying abnormalities in the blood, such as hyponatremia, hypocalcemia, hypomagnesemia, hypoglycemia, as well as low oxygen saturation. When any of these are identified in a patient, it is more important to correct these abnormalities rather than immediately prescribe an anti-epileptic medication. Toxic seizures can occur due to adverse reactions from prescribed medications as well as illicit drugs. They can also occur due to withdrawal from these drugs. In this case, the important thing to do would be to stop the medication. Toxic seizures can also occur due to renal failure, where the kidneys fail to excrete toxic substances from the body, causing them to build up and affect the brain, causing seizures. In this scenario, it would be important to treat the renal failure with medications or dialysis prior to considering anti-epileptic medications. Convulsive syncope can occur due to an underlying heart condition. The heart fails to adequately pump blood to the brain and the rest of the body, not supplying adequate glucose and oxygen to the brain, resulting in seizures. Again, here, the most important thing would be to treat the underlying heart condition rather than the seizure itself. Acute concussive convulsion can result from an acute trauma to the brain. In this scenario, it would be important to treat the underlying concussion. However, if there is a risk of further seizures, and anti-epileptic medications may be considered, depending on the type of trauma. Seizures within the first week after a brain trauma, infection, or stroke is considered a provoked seizure, and these underlying conditions must be treated first. However, following the first week, brain trauma, infection, or stroke can leave lasting changes in the brain that can act as a focus for epileptic activity. In these situations, if seizures occur after the first week, they are considered unprovoked seizures, and the person may be diagnosed with epilepsy, and anti-epileptic medications may be considered. We will review these in clinical scenarios later in the session. When is epilepsy resolved? Epilepsy is considered to be resolved for individuals who had age-dependent epilepsy but are now past the applicable age, or those who have remained seizure-free for the last 10 years with no seizure medications for the last 5 years. As we have discussed before, there's varying consensus on when epilepsy is considered to be resolved and when a patient should be taken off medications. There are multiple factors to be considered prior to stopping medications in an epilepsy patient. As mentioned, we will discuss this in more clinical context in later sessions. However, at this time, it's important to remember that preconceptions associated with the words cure and remission should be avoided. Resolved has the connotation of no longer present, but it does not guarantee that epilepsy will never come back. And this has to be clearly discussed with the patient before epilepsy is considered resolved. Classification of epilepsy. Why do we need to classify epilepsy? 1. For the purpose of clinical diagnosis, as well as to clearly communicate our findings, and in turn to create a better treatment plan. When the clinical picture of epilepsy is complex, or history and information is limited, using transparent and standardized language can help us describe our findings more effectively. Here we have the old as well as the new classification by the International League Against Epilepsy. On the left, you see the older classification, which is the one we are all familiar with. Primary generalized seizures, classified into grand mal or tonic-clonic seizures, and petit mal or absence seizures. Then we have partial seizures, which are the simple partial, complex partial, and simple secondary generalized seizures. In this situation, you use the word simple when there is no loss of consciousness and complex when there is loss of consciousness. And finally, you have status epilepticus. In the table on the right, you see the new classification by the International League Against Epilepsy. Although the older classification is no longer recommended, it is still widely used and it's important for us to be familiar with it. But it's also important moving forward for us to know the new classification. In the middle of the table, you see generalized onset, which is motor, tonic-clonic seizures or other motor seizures, and non-motor or absent seizures. This pretty much coincides with the older classification, except we no longer use grand mal and petit mal. On the left, you see focal onset seizures, which is the equivalent of partial seizures. So instead of the word partial, we use focal, which is more descriptive of what is occurring in the brain. And instead of simple and complex, we use aware and impaired awareness. Aware in that there is no loss of consciousness and the patient is aware of the event, and impaired awareness where there is loss of consciousness. And this is broken down into motor onset and non-motor onset. Motor onset if there is jerking of a limb or some part of the body, and non-motor onset if there's a sensory symptom, for example. And instead of secondary generalized, we describe the event more clearly, which is focal to bilateral tonic-clonic. And on the right side of the table, you see unknown onset, where we don't know how the seizure started, but we know how it ended, which is either a motor, tonic-clonic seizure or other motor seizure, or a non-motor seizure. And finally, we have the more complex varieties, which is considered unclassified. What is a generalized seizure? A generalized seizure originates at some point within the brain and rapidly spreads and engages multiple parts of the brain bilaterally, in turn affecting the entire body of the patient affected, resulting in a generalized seizure. What is a focal seizure? A focal seizure originates within a specific part of the brain, typically limited to one hemisphere, resulting in a seizure in the corresponding area of the body that is controlled by this specific part in the brain. This slide shows a schematic representation of what an EEG looks like. In a normal brain, the EEG shows normal wave patterns across the board. With a focal seizure, the EEG will show abnormalities in only some of the waves, and in a generalized seizure that affects the entire brain, the entire EEG will show abnormal waves. In order to make a diagnosis, we need certain information. We need a detailed history from the patient and caregivers, a detailed neurological and physical examination. We need investigations and imaging of the brain. We also need to investigate the underlying causes and assess comorbidities. Depending on the amount of information available, a diagnosis can be made at 3 levels. Level 1, seizure type, Level 2, epilepsy type, and Level 3 by epilepsy syndromes. For example, at a health center level, a health center nurse may be able to take a detailed history, may or may not be able to perform a detailed neurological exam, and may not be able to avail of more detailed investigations. In this scenario, a Level 1 diagnosis of seizure type can be made based on the history provided by the patient. This can be divided into focal, generalized, and unknown. At the district hospital level, we can perhaps get more detailed history and do a physical exam, order blood tests and brain imaging, and further investigate underlying causes. In this situation, a Level 2 diagnosis may be made based on epilepsy type. This is divided into focal, generalized, combined, generalized, and focal, or unknown. And finally, a Level 3 diagnosis by epilepsy syndromes can be made perhaps at Ndera, where they have much more detailed investigations available, and may be beyond the scope of the context in which we work. This table simply summarizes the 3 levels of diagnosis by seizure type, epilepsy type, and epilepsy syndrome. It is important across the board to always consider underlying medical comorbidities that you see on the left and underlying causes, such as structural changes to the brain, genetic predisposition in a patient, infections, metabolic causes, immune-mediated causes, and others. Now let us summarize what we have learned in session 1. A seizure is the event or symptom. Epilepsy is the disease associated with spontaneously recurring seizures. Epilepsy is diagnosed when there are at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure with a probability of further seizures, or a diagnosis of an epilepsy syndrome. And to review the ILAE classification of seizure types, there is generalized onset, broken down into motor, tonic-clonic, or non-motor, absent seizures, focal onset seizures, which can be aware without loss of consciousness or impaired awareness with loss of consciousness, motor onset or non-motor onset, and finally, unknown onset, motor or non-motor, or unclassified. Now, let us review a few clinical case scenarios to try and apply these definitions and classifications we have learned so far. Case scenario 1. A 7-month-old baby girl presents to the emergency with high-grade fever. While in the emergency, she has a generalized tonic-clonic seizure. Is this considered epilepsy? Think of your answer before you proceed to the next slide. The answer is no, she does not have epilepsy. The baby had a febrile seizure. As we have discussed, this is a provoked seizure and has a clear, acute underlying cause for the seizure, so she does not have epilepsy. She will not need to be started on an anti-epileptic medication for the febrile seizure. Clinical scenario 2. A 25-year-old woman presents to the clinic after having a seizure this morning. The The seizure lasted 3 minutes. She was confused immediately after, but is now back to her baseline. She reports that 3 years ago she had a seizure that was similar, but she was not treated after the first one. There was no cause found for either seizure. Does this patient satisfy the criteria for the clinical diagnosis of epilepsy? Yes or no? The answer is yes. Let's review the definition of epilepsy. At least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure with risk for recurrent seizures. In this patient's case, she has had 2 unprovoked seizures occurring more than 24 hours apart, 1 3 years ago and 1 today, and therefore she satisfies the criteria for the diagnosis of epilepsy. Clinical scenario 3. A 65-year-old man had a stroke that you see on the attached image. The stroke occurred 6 weeks ago, and he now presents with an unprovoked seizure. He has no prior history of seizures. Does this patient have epilepsy? Think about your answer before you proceed to the next slide. In particular, consider the timeline of the stroke and seizure. Before answering the question, let's review a previous slide where we listed types of seizures that are not epilepsy because they occur due to an underlying precipitating medical condition. If you look at the last point, we talked about seizures that occur within the first week after brain trauma, infection, or stroke are considered provoked seizures and therefore not epilepsy. However, in this patient, the seizure occurred 6 weeks after the stroke. This is not considered acute and therefore is considered an unprovoked seizure. And because a stroke can leave lasting changes on the patient's brain, it puts him at a high risk for future seizures, satisfying the second point on the definition for epilepsy, which is 1 unprovoked seizure with a risk for recurrent seizures in the future. Therefore, to answer the question, yes, this patient can be diagnosed with epilepsy. If the seizure had occurred within 1 week of the stroke, it will be an acute symptomatic seizure or provoked seizure. Beyond 1 week, as in this case 6 weeks, where there is no other acute cause found, it is considered an unprovoked seizure. Although he has had only 1 seizure, post-stroke is a very high risk for recurrent seizures, so he satisfies criteria 2, and therefore this patient has epilepsy. This brings us to the end of session 1, an introduction to epilepsy. Murakoze Chani, thank you for your attention. Please feel free to share your feedback, questions, and clinical cases on the WhatsApp groups or via email so we can continue to learn. I look forward to session 2.